Forget the EMR. We need to work on the PMR.
Whew. All right. Data, 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 data. It's like it's pretty much of a common theme this morning. And today we're talking about forget the EMR. We need to work on the PMR. What's a PMR? There's just 3 letters? No, not really. It's a personal medical record. And each and every one of you who highly likely has a smartphone already has a PMR. Think about it. Just with one device, you have that. And our panelists have already been introduced, so I'm not going to go into introducing each and every one of them. And I'm going to dive deep here with Hugo. Hugo, you come here with a wealth of experience. And from this experience that you had so far, what is the current state in Europe when it comes to electronic medical records? And are there any good case examples or case studies that we can follow and learn from?
Well, thanks for the invitation, first of all. Stefan, it's great to be here and have this audience. I wouldn't forget the EMR at all. It's very important that our healthcare providers continue to take good records, have that complete data, which we heard about from the previous session. There's a wealth of good practice examples across Europe and the rest of the world. And that will remain the cornerstone of medical record keeping for healthcare providers.
Exactly.
That's what's different with the personal health record, which you tend to call it, perhaps it's commoner to call it PHR, is that now we've got the patients in on the act. Let me start from Malta. In the case of Malta, the first PHR development is probably the My Health portal. This is a national portal. We created it not long after Mater Dei Hospital, our main hospital in Malta, opened in 2007. And the purpose was to bridge the communication gap which arose between healthcare providers working for the government sector and private GPs who were left out. So Mater Dei had its new systems, its brand new PACS and lab system and order communications and its own EPR. The family doctors, who are our main contact with the people out there, weren't in on this. So we thought of My Health in 2 ways: to pass the data over to the private GPs, but also start getting patient empowerment. And that's what we did, because only the patients themselves can log into My Health and give access to doctors to see their records. And that was the start of our real national PHR. But it doesn't go far enough, because so far you only have access to little bits of information, well, important, but part of the information from hospital. And in our plans now, we have to get patients more in on the act. And a lot of them are asking for it. They want to upload scans of their documents. They want to catch data from their wearables. They want to have devices which are more than wearables, 𝐂𝐸𝐬𝐧, whatever, and pass that data because they want to share that data with their healthcare provider in their own interest.
Yes, Hugo, in fact, you're reminding me, like even on, for example, on an Android or Apple smartphone, you can actually put in your blood pressure. Imagine that going back to My Health.
Absolutely, absolutely. And the big challenge, and I know some of the panel have worked on this, is to join the EMR with the PHR. Now, over above all this is the EHR, the electronic health record. And I know it sounds like an alphabet soup, but there are differences in concept. And the EHR is that longitudinal record, which should be available to all healthcare providers who come into contact with the patient, mainly for the life-saving information like allergies and drug history, but for more than that. And there are many good examples now developing in Europe. You can look at Germany, you can look at Norway, you can look at France. They're state-sponsored efforts to pull the data together with the patient at the center. So yes, that's the way we're going. So we continue providing healthcare providers, not just in hospitals. For example, in Malta, one of our recent developments was the implementation of an EPR for primary healthcare. Our government GPs we're still working with almost only with paper. There were some systems for specific use cases, but not an all-encompassing. And as you know, because you were very much on the rollout, Stefan,
Yes.
that's created yet another important data source which we need to integrate for the good of the patient.
Yeah, I think now what's interesting, like primary healthcare, how they took a lead in this is like really fantastic. I want to switch now to Ardy, Khalid, and John. And you know, as I mentioned before, each and every individual basically now has access to their own, the 3D personal health record. They can actually manage in a structured way. Pretty magical, right? In a structured way. So how do you see now all of this coming together with electronic medical records, data sources from other locations? Maybe starting with you, Ardy?
Yeah,
and
I
then
think.
Khalid and John?
Yeah, thank you so much again for having me here, Stefan and Dylan and the organizers here in Malta. It's just been amazing. I think a couple things. One, patient centricity has been front and center more so than we've ever seen.
Okay.
And I've spent a lot of time with our team pioneering actually patient-centric interoperability. We'll talk about that after this panel. I have the keynote on a lot of the topics that Hugo was mentioning, so it's nice to hear about Seqster without even saying it. So I think a couple things. Number one, you know, globally, I think we are more connected and disconnected than ever before. I'll say that again. We are more connected and disconnected than ever before.
You intrigue me. What's this all about, Ardy? Tell me.
Yeah, so I think because of the pandemic, it allowed us to accelerate digital health, right? Number one. But what people don't understand is that data silos are happening beyond just EMRs, right? You mentioned wearables. You know, I spent 17 years before founding our company, Seqster, for seeking health data in regards to DNA sequencing. And so it's not just your EMR records, it's not just your wearables or sensors, medical devices, social determinants of health data. There's lots of different data out there. And you know, Ruthie from Microsoft did a fantastic job earlier, kind of giving us a nice overall picture of that. But data silos and interoperability is giving, you know, reason for patient engagement and data-driven technologies in order to, you know, put the person at the center and connect all that data through the data ownership and GDPR. If you're in the in Europe, and if you're in the US, you know, you're regulated by the FDA and HIPAA and lots of other things. So this is what's really interesting to me, is the fact that every single person at this conference has some sort of data, and some of it is connected, and a lot of it is not. And you think you have it all connected. You actually don't. The technology exists, but this is where there's a huge disconnect. And it doesn't matter if you're a physician, a provider, a payer, a big consumer brand, such as Amazon that's getting into healthcare. It doesn't matter. At the end of the day, I think, again, we are so connected, but so disconnected.
Wow, that's something to swallow, but definitely we have to do something. Maybe Khalid and then John?
Yeah, I couldn't agree more with Ardy actually about this. And I have actually a personal story to share about this.
Oh, tell us.
My mother died in 2017 due to a heart condition. She went through, under the knife a few times. And we have in the Netherlands, there is one hospital who specializes in heart surgeries. But she was under treatment in another hospital. And they actually follow the same group. It's the same system. It's under the same umbrella. When she was transferred to the other hospital, all the records with her consent were shared with that hospital. But after the surgery, we found out that she wasn't waking up. And we wondered why. Why everything went well. It was a successful surgery, and why she's not waking up. So we discovered that her liver was creating ammonia, which prevented her to wake up. And that record was not shared from the other hospital, which actually, you know, for me it was like, of course, a personal trauma, But later on, when I started Tykn, on the field of digital identity and self-sovereign identity, we thought this should be fixed. I'm actually, our company is now innovating 5 years in the field of digital identity. We have done projects with NGOs, governments, but actually recently, due to COVID-19, we saw that there is an emerging market within the health tech, especially now with this GDPR-like regulation popping up everywhere, especially also in the United States, where every association or hospital is panicking about how should we process data, how should we manage it. So for example, one of the biggest medical associations is actually using our technology to help them verify physicians so that they actually know that we are dealing with real physicians and not just fake ones. They want to onboard physicians in a way where data is controlled by the person and they have autonomy about their data and who they share with selective disclosure and also with other technologies which come to that. So yeah, I agree on the terms that the future is going toward more autonomy on your data, but also this is for me the reason why actually I'm here, and I'm honored also to be here in this panel.
Just remind me, Khalid, how do I pronounce the name of your company? Tykn?
Tykn.
Tykn?
Yes.
Tykn. All right, I have to remember that. I'm sorry about it.
We have heard it all. It's Tykn, Token, Tykn, so we have heard all the versions.
All right, Seqster, Tykn, okay. My head, that's a bit, it's quite easy, But John, tell us your thoughts.
Does it work now? Yes, great.
Great.
So good afternoon, everyone. It's a pleasure to be here. Pleasure to be part of this wonderful panel. Thank you, and Ardy, I totally agree with a lot of what you said as well. Khalid, thank you for sharing that personal story. It's always very sad to hear situations that could be avoided, like in your own family. I guess I want to start by talking about, what's been spoken already a lot today, but that's about this, whether you're talking about an EMR, EHR, PHR, it really comes down to the aggregation of the data and the quality of the data and the interoperability of, these different platforms. And I think that, we're still in the infancies of where we need to be. So the EMR was, for example, a first version, let's say, that was used primarily at one provider. That evolved over time to an EHR, which is now something where you can share data across multiple providers. And it's getting there, but it's still a long way to go. So I think one of the big issues is how difficult it is for clinicians to actually access the data today in an EHR, EMR. So many different screens, so many different touch points. The average clinician in the United States spends 6 hours a day in front of using the EHR. And that's just too much. They need to be spending time with the patient.
Yeah, in fact, you're reminding me, John, sorry for butting in here, but I remember I had a situation at work where I was introducing a system, and something which, when I go there to the conversation, oh wow, this is really great, it's going to change their lives, it's going to have the information at their fingertips. And then, guess what was the first reaction? Oh, yet another system, oh no, how I'm going to deal with this? And that is the reality, because sometimes, because of all the energy we have to bring things together, we kind of sometimes have challenge to bring in the human behavior aspect for us. So, John, I'm sure you had something more to say about that.
I think, when it comes to, so if I can use our own example, so yeah. I'm a startup founder, the company's called PIPRA, and we're dealing with one very specific thing, which is post-operative delirium. It's a cognitive complication that arises after surgery. It's the most common post-surgical complication. We spent 1.5 years collecting, harmonizing, and aggregating data from all over the world in order to have insights, data-driven insights, into one very, very specific niche thing. And it was a huge collaborative effort together with academia. So there's still a long way before we can really get the insights that we need out of whether it's an EHR or PHR. I think there's a lot of benefits that happen today, but I think we need to find solutions that work together where when you talk about sharing data, so you're not just compiling more and more data points that don't actually give you quality insights. You need to be able to quickly identify, this is the patient, this is their history, this is what's relevant, and now I want to spend time with the patient. And when it comes to the PHR, it's so early, it's in such infancy. You know, what works for a 30-year-old doesn't work for an 80-year-old. And you need something that works for everyone. So I think it's for me personally, I think it's the responsibility of the technology providers and the hospitals to really, you know, make that transfer of data to the patient. Help them, make it an easy transition, and not rely so much on the patient to, you know, to figure out their way around their own data. As I said, an 80-year-old is going to struggle with that, obviously.
Yeah, you're reminding me actually of data stewardships.
Yeah.
So I think that idea is definitely something we need to advocate for. Having someone telling you, listen, your data is here. I'm not saying like a computer program necessarily, but someone explains to you, listen, that your data is here, and here right now. We need it for this specific reason. So it's not, so even like this, you kind of create a relationship with the patient to understand, like, listen, there's a reason for it. It's not just there so that we can get to know more about you. And that's where the communication principles come in here. And like one big challenge, and this will take some time to answer, and I'm going to start again with Hugo, if that's okay. How do we leverage and connect all these different data sources? So we're dealing with legacy systems, we're dealing with innovative systems, we're dealing with AI. Now let's add distributed ledger technologies. You have like this soup that we're kind of creating, but now how are we going to get the taste out of that soup?
So I have some comments there. Without, you know, teasing the crowd too much about the presentation that will come next that will fully cover that. I think there's three main things there. Number one, I think John said it, it's normalization and standardization and harmonization of data is extremely difficult. When you're dealing with different disparate data sources and disparate systems, especially from the hospital standpoint, if we take, you know, an Epic system, a Cerner system, and an Allscripts system, they don't talk to one another. And, you know, forget about, you know, just vitamin K or vitamin D being, you know, listed differently in different versions of the system. But all those ICD-9 and ICD-10 codes and all the medical terminology, you know, the nomenclature, standardizing and harmonizing all the SNOMED stuff and the RX norms on the back end. It's a big, heavy lift from the engineering side. So, you know, we can't forget about all of the engineering, software engineering that has to go into place, and AI isn't going to do it. AI is worthless without the data. Data gives AI weight. And so once you have both, then you can layer in insights and analytics and all these great things that we all talk about at these conferences. But more importantly, I think you have to have a system that can rapidly aggregate, standardize, harmonize, and visualize that data, hitting on semantic, structural, and foundational interoperability.
It's starting
That's
to sound like a
real.
data pipeline to me, Ardy, the way you're speaking, like harmonization, you know, these are keywords that we definitely have to bring into the healthcare scene. It has to be normal, the idea that we harmonize. I want to go quickly switch to Hugo, and you feel free to chip in on what Hugo says. And then I'll go for Khalid and John. Hugo, I'm not sure you want to chip in here on this. Huh?
Well, I agree entirely with what Ardy said. It's about standards, really. I can say what we're trying to do in Malta to tackle this big problem,
Go for it.
which is our national electronic health record system, which is basically a big data store. But for things to join up in that data store, you do have to have standards from the word go. And that's one of the reasons why Malta was an early joiner of SNOMED International, because we do believe that SNOMED City is the best terminology, clinical terminology out there, and it covers so many domains of terms which are used by doctors in their records and other health professionals. If we can get people to articulate their data and produce good quality data at the coal face, that will reap all the benefits down the line. As you well emphasized, Ardy, AI isn't anything without good data substrates to work on. So yes, we have to catch it from the creation of the data. And linking to the previous discussion, that's even for patients. They can record stuff as well, and we can offer them lookups with standard terminology, and that will serve us in good stead. Yes, we can try to analyze blocks of free text, but can only get so far with that. If we can get people more disciplined in the data capture point, then systems like Ardy's will work even better, you know, and ours, the NEHRs in future. One thing which we should mention is that, and this mirrors what's happening even on the European stage, is that we shouldn't only think of primary use, but also secondary use of data. And that's where EHDS1 and EHDS2 come in on the European stage.
What is ehds, Hugo?
Sorry, EHDS is short for European Health Data Space.
Oh, nice.
And it's being broadly divided into 1 and 2 to make a clear distinction between primary use of data by the health professionals actually giving a service to patients, and secondary use, which is for other purposes like clinical research. And we do know that many patients, as long as you protect their data privacy, their privacy and confidentiality, are ready to let their anonymized data be used for secondary use. So yes, that's a place we have to develop further, and that was how we reap the benefits for public health, for the whole collective, and not just for the individual patient.
Population health interventions, quite a lot we have to learn there. Ardy, I cut you off, I apologize for that. But did you want to explore further this topic?
Yeah, no, I think Hugo hit it right on the spot. You know, high fidelity, high quality data is what we should always be striving for. And the best way to get high quality, high fidelity data is actually through the patient. Allow the patient to create instantly a longitudinal health record in real time. I'll talk about that later on the talk.
Okay. No, so I'm trying to imagine like trying to teach my 3.5-year-old son, like, listen, you should use that terminology for that particular condition, like imagine like through primary school. But there is a role for sure in education is to teach about structure and awareness and digital health literacy. Definitely there is something to do there. And with that in mind though, I'd like to move a bit now into artificial intelligence techniques and distributed ledger networks and the technology behind it. And I'm sure that Khalid and John have a lot to say about this. So we'll start with you this time, John, because first we let you at the end and now you're at the forefront. Tell us, what are your thoughts?
Yeah, lots of thoughts. I mean, so as I mentioned, so for us, you know, artificial intelligence, you know, Ardy said it very well. You know, it's all about the quality of the data, and if you want to have a reliable artificial intelligence, for us, it's a clinical decision support software. So if you want something that's helping support the clinician in making a decision, it needs to be better than the clinician, or at least it needs to be objective, and it needs to be based on a lot of quality data. So we spent a lot of time really looking for the right quality data first of all. So I think that's really key when it comes to AI. When it comes to, you know, distributed ledgers, I don't claim to be an expert in that field. Might pass that on to you, Khalid. What are your thoughts?
Khalid, the floor is yours.
I just want to bounce one thing back, is that we shouldn't reinvent the wheel, right? And we shouldn't also educate patients. Why I'm saying that, I'm coming from a user experience background, right? And we should use certain mental models that people already know and have already in place. So, for example, and what we are actually innovating in the space of decentralized identity, and all the thing that we do all the time is actually reinventing the wheel, which is not a good idea, right? So So, and we have actually, just to resonate with your previous question, we hear a lot of panicking employees telling us like, I don't want to use a new system. We have faced that many times. Our technology is agnostic and it plays in different sectors and industries. But what you see is that people don't want to use a new system. They don't want to take out their legacy system and coming up with something totally new. What they want is to have a simplified access to which is something potentially be more beneficial than the current systems, but without actually replacing the mental models and the way how they structure stuff. So for example, what we did, and we have been fallen on our faces many times on this, is instead of teaching organizations or users how to deal with wallets, blockchain solutions such as decentralized identity or self-sovereign identity, we just simplified it as what they are using now. And for the organizations, we kind of break down the barriers where they could use the technology such through an API call. You don't have to understand how blockchain works. You don't have to understand how distributed ledger technology works, or how you set up schemas, or how to have certain standards which actually now are being more adopted by governments and bigger organizations. So I think that's the key message I want to just cross here, is that let's not reinvent the wheel how some things work, especially in the healthcare sector. I don't have as much experience all the panelists on the healthcare sector, but we do see that there is an emerging market that really needs some guidance how they use a new technology without having to really learn things from scratch.
Thank you so much, Khalid. I just want to give the opportunity now, because also we're running out of time, believe it or not, since it was such an interesting discussion. Thank you for that. I want to give you an opportunity for a 30-second takeaway from this session, from this very open discussion, from people from all different experiences. And I'll start off with Hugo once again, and then go Khalid, Ardy, and John. Like 30-second takeaway. The floor is yours.
Okay, well, the focus of the session was the personal health record, and my final message is engage with the patients for whom, or persons, because we hope to catch them before they're ill, for whom the personal health record is being built, and to have to engage with it, because that will ensure its success.
Thank you. Khalid.
I will just emphasize, let's use the standard mental models people already know. So they don't have to relearn anything else new, with adoption, of course, of new technologies and new solutions that might help them, have more autonomy on their data better.
I'm going to throw a left field here, okay? Wow. I think I would boil it down so that I don't repeat anything that I said to, we need the Netflix of healthcare. And that's what we need for the world. Not for just Malta or Europe or the US or the Middle East or PAC Asia, for the world, the same way that you can be anywhere in the world and get any video on your Netflix. That user experience of healthcare is not there. People are hungry for it, physicians need it, providers need it, payers need it, overall system needs it, governments need it. We're a long ways away, but there's lots of technology that can actually deliver that. Really excited for that.
Boy, Amazon and Apple are going to be pissed.
I watch a lot of Netflix on my flights, so I can't buy anything off Amazon on my flights.
At least we need the data engineers of Netflix in healthcare. Yeah. That's for sure.
There you go.
John.
I guess I would just close by saying, the question is, forget the EMR. Do we need do we switch to the PHR, right? And I think we need both. I think they both need to continue to evolve and get better. And we're getting there, and it's exciting. But there needs the input from the patient, and it needs the input from the clinician, and they need to work harmoniously together to get to a place where the data-driven insights really support the patient. And I think in terms of AI, one of the exciting things in the future is, for next gen, is prescriptive AI. So it's not just giving you a score, it's actually making a recommendation for what can be done for this patient. That's exciting at both sides.
Thank you so much, everyone. And with that in mind, I'd like to close the session. And I want to give one big shout out to Dr. Dylan Attard and Dr. Ryan Gregg, who without them, this conference wouldn't have been possible. Thank you, everyone. Big clap to our audience and panel, sorry.